All right, so this is Dr. Lisa Kallenbach. She is a medical oncologist who has been working with our team for many, many years in Rwanda. Have you worked in Haiti as well?
No, I wasn't in Haiti.
So in Rwanda, and now she is a group medical director at Johnson and Johnson Innovative Medicine. And she is going to be giving a talk on chronic myelogenous leukemia. As you guys know, we are now getting CML drugs covered by the Max Foundation. So this is just a larger review of the disease and how to treat it. Um, and with that, I'm going to pass it off to Lisa.
Okay. All right. We are going to start with just a little pre-quiz, 3 questions, and at the end we'll go over them, but just to sort of get you into the mindset. So the first one is, what type of disorder is CML? Is it a solid tumor, a myeloproliferative disorder, a leukemia, or both a myeloproliferative disorder and a leukemia? Next question. You can sort of tuck away your answers. What's the main therapy used long-term to treat CML? Hydroxyurea, prednisone, imatinib, or Rituxan? Next, what's the translocation that's most often associated with CML? The Philadelphia chromosome, which is translocation 922, c-MYC translocation, which is 814, or the BCL2 mutation, which is 1418. Next slide. Okay, so today, I'm hopeful that at the end of the session, you will be able to describe the basic epidemiology of CML, the pathophysiology, recognize signs and symptoms, and how to diagnose it, and then describe the treatment, including the use of imatinib or Gleevec, how it works, the side effects, and the long-term follow-up for patients with CML. Next slide. So we're going to go through the epidemiology. So CML accounts for about 15 to 20% of all leukemias in adults. There is an increasing incidence with age. The median age at diagnosis is 65, but it can be seen in all age groups, including pediatrics, but it's unusual. There's no known association with a race or ethnic group, and the only known risk factor is ionizing radiation. Next slide. So now we're going to look at the pathophysiology. Sorry for my... So this is a myeloproliferative disorder, which means there's like a clonal uncontrolled production of these transformed hematopoietic stem cells. And they are predominantly neutrophils, but also basophils and eosinophils. And so what you see there, what you see there is like a whole range of the myeloid spectrum, from mature to immature myeloid cells, both in the marrow and in the peripheral blood. Next slide. So the causes of CML. So it is typically caused by a reciprocal translocation between chromosome 9 and 22, which is called the Philadelphia chromosome because it was discovered here in Philadelphia, which is where I live. So it's right here. It results in a unique protein being formed, the BCR-ABL fusion gene that produces a protein that acts as a kinase and drives this proliferation. So you get a uncontrolled growth of just and no maturation. There's no stop for maturation. And it really is just, I think this causes like 98% of CML. Next slide. So let's look at signs and symptoms. But sorry, I wanted to say one other thing about the 922. So that translocation was really the first time that we found the exact driver mutation that caused a disease. So the treatment of CML really represents one of the first, quote, designer drugs where you could really target that mutation and treat a disease. so effectively. Next slide. Okay, so let's look at signs and symptoms. So there are different phases of CML. There's chronic, accelerated, and blast phases. The chronic phase is the one you'll see most often. This is when we usually diagnose CML because you'll either pick it up on a CBC or people will have symptoms and they'll be in the chronic phase. So about up to half of patients will have no symptoms, and they'll just be diagnosed on a blood count. But some people might be really tired, have weight loss, night sweats, abdominal fullness from an enlarged spleen. Next slide. In the accelerated phase, so it's a little bit more difficult to control the leukocytosis, and there's decreased differentiation of that neutrophil line. So you'll see more blasts and less of the mature white cells. And in blast crisis, that's actually acute leukemia. So you'll have over 20% blasts in the blood and in the marrow. And worsening of the cytopenias, the anemia and the thrombocytopenia, because the bone marrow is being crowded out. In the more accelerated phases, you might see things like shortness of breath, priapism, visual changes, and bone pain. But it's important that, and fortunate that we typically see it in the chronic stage because it is the stage that's easier to treat and easier to control. Next slide. So when you are determining whether or not somebody has CML, the differential includes a leukemoid reaction. So you'll get non-malignant granulocytic cells because there's been an infection or some sort of inflammatory stimulus. So you really do need to find out if people have been sick recently, had specific, long infections. There are other myeloproliferative neoplasms like polycythemia vera, essential thrombocythemia, and chronic myelomonocytic leukemia. They look different on the slide, on the peripheral smear, and are associated with different mutations. And then other leukemias to consider if you're in an accelerated phase, you want to make sure it's not AML or Philadelphia chromosome positive ALL or lymphoblastic lymphoma. So those are the other leukemias to consider if you're looking at a leukemic picture on a smear. Next slide. So things that you need to check when you're trying to make the diagnosis. So the full blood count, obviously, because that'll show you if you're in chronic phase, accelerated phase, or blast phase. So in the chronic phase, you'll see more leukocytosis with that full spectrum of granulocytes, and often an eosinophilia and a basophilia. And you might see thrombocytosis. You might see high platelets because it is myeloproliferative, and mild anemia. Whereas when you get into the more accelerated phase and blast crisis, you'll see more cytopenias and blasts. And then the peripheral smear, you can see exactly that full spectrum, right, of granulocytes. And in the marrow, it'll look very much like the peripheral smear. And interestingly, you don't need a bone marrow to make a diagnosis here, which is nice for the patient. Next slide. What you do need is genetic testing. So for the diagnosis, you have to show that BCR-ABL1 fusion gene or its products are there. And you can do that in a lot of different ways. You can look at cytogenetics. So you could see that translocation of 9 and 22. You could use FISH using DNA probes that would detect the BCR-ABL1 fusion gene. But more often we use like an RT-PCR, where you use primers to amplify that fusion mRNA transcript. And you can do it on peripheral blood or bone marrow, but you can do it on the blood, which is great. And we use something called Gene Expert, which I understand you have. And that's what they use in Butaro. And I wasn't sure if you had it yet or not. So that's why, it says that they use it in Butaro. but it uses a specific primer to detect the P210 transcript, and that's the transcript that is most common. So it's in over 90% of cases of CML. The white blood cell count to make this an accurate test needs to be less than 200,000. And in order, if your white count is higher than that, there is a dilution protocol to maintain that accuracy. And then there's also another transcript called P190, which is seen in about 9% of cases, and a P230, which is seen in less than 1% of cases. So if you really think this is CML and the gene expert is negative, then you actually have to do more testing to make sure, like a qualitative PCR, to look for that 190 or P210 transcript. Are you guys having an okay time hearing me? Because it keeps saying my internet connection is unstable.
You've been very clear to me.
Okay. All right. Just checking and getting these messages. Um,
Lisu team, are you hearing well?
You're hearing well.
Okay,
okay.
perfect.
So I understand you guys have Gene Expert and that hopefully you're going to have cartridges in January. Fingers crossed. Okay, next slide. So now we're going to go into the treatment of CML and how that drug works. Next slide. Okay, so when you first have a patient with CML, the goal is to lower that blood count quickly. And you can use Hydrea while you're making sure that this is CML. And that will lower the white count very quickly. It will cause, other cytopenias as well. The hemoglobin and the platelets will drop as well. And then you want to start people on Gleevec. It used to be that the only cure was allogeneic stem cell transplant. And the presence of imatinib has really changed the algorithm. And allogeneic transplant is still used for people who don't respond to any therapies. It is still available, but it is not commonly used because Gleevec is so effective. If you're in the chronic phase, it'll take about 2 to 6 years, but you will eventually evolve to blast crisis. And then if you are in blast crisis, that's when the stem cell transplant really comes into play. And it is hard to cure at that point. Next slide. So the dosing of Hydrea when you first use it is 2 grams a day orally. And you have to continue that until the white count is less than 50,000 and then transition to Gleevec. And really watch the other counts because it does cause pretty significant anemia. Gleevec is used in patients who have confirmed BCR-ABL fusion gene, and the dosing is 400 milligrams once a day to start, and then you can titrate based on the response up to a maximum of 800 milligrams a day. Nilotinib is your second-line therapy, and this is only used if there's Gleevec failure or Gleevec intolerance. I feel like the bottom of this slide got cut off. Sorry. And the dose is 300 milligrams twice a day. The issue with nilotinib is that you have to take it 2 hours. You can't eat an hour before or 2 hours after taking the medication. So that makes it kind of challenging for patients. And so it's not the ideal therapy for patients who aren't used to taking medications and then to have to really make sure that your stomach's empty when you take it. But it is a great drug. And it is the only second-line therapy provided by the Max Foundation at this time. Next slide. So imatinib, again, was the first designer drug in the United States that was approved in 2001. It resulted in a major cytogenetic response 92% of the time. The progression-free survival was 84%, and yearly progression was 4%, which is very low. And relapse to accelerated phase and blast phase was even lower at 2%. And what it does, the drug actually sits in this pocket where that ATP is. So the way when you have CML, this phosphorylation of this third phosphate onto the cancer protein causes the constitutive like on button. And imatinib just sits in there in that same pocket and blocks that transfer. And then you get regular differentiation. And the first thing you'll see when you look at the smear of a patient who's taking imatinib is that the smear starts to normalize pretty quickly. Next slide. So imatinib, the advantages of imatinib is that it's oral, it's once a day, it provides long-term disease control, and it is available worldwide. The disadvantages are that typically you need lifelong therapy. There are specific cases of patients who can come off of therapy, and we'll go into that, but it requires very close monitoring, achieving a major molecular remission pretty quickly, like within 9 months, and then maintaining that very deep remission for about 4 years or before you can even consider coming off. So most patients, in most cases, will be on lifelong therapy. The other issue with any oral medication is compliance over time, right? Patients, it's hard for people to take pills every day. And when they start to feel better, they don't think they need to take pills anymore because they're feeling better. So it is hard to be in that mindset that you do really need to take this pill every day for the rest of your life, pretty much. And then there is resistance over time that can develop, and there are side effects. So let's go into that a little bit. Next slide. So Gleevec definitely causes, hematologic toxicity, low white count, platelets, in about 15% of cases. Sometimes elevated liver function tests. It's most well known for edema, like swelling and CHF, rash, alterations in bone metabolism. Autoimmune issues are rare, but can occur. But I would say most people with either a short break in therapy can really have control over those side effects and stay on imatinib. So just because somebody comes in with diarrhea once doesn't mean they need to switch to second-line therapy. That's not intolerance to the drug or severe toxicity. It's when you can't manage those side effects over time, because typically within 3 to 4 months, people do get used to the drug and the side effects get better. So I encourage you to really work with people to see how they're doing and give it a good, 4 to 6 months after they start before you consider changing therapy because of side effects. Next slide. So response to imatinib is measured, and response to any drug for CML is measured with first a hematologic response, then the cytogenetic response, and then what we look for is that major molecular response. So you don't even want to be able to detect that transcript on your RT-PCR. So within the first 2 months, or 3 months, sorry, you really want to see that white blood cell count come down less than 10,000. You don't want to see any immature myeloid cells and less than 5% basophils. And the platelet count you want under 450,000. And you don't want to have any more palpable spleen. Then by 6 months, you really want to see a cytogenetic response where you look at the chromosomes and, there's no longer there's no longer the translocation seen. And you need to look at more than 20 metaphases to be able to look at that. And then the molecular response is on your gene expert. So this is a log reduction in transcripts, and you want to see the goal is less than 0.1% at a year. That is a major molecular response. And along the way, if you're not hitting those time requirements, then you consider either increasing the dose of imatinib, changing therapy, things like that. And we'll go through that because it's complicated. But you definitely, in this order, want to achieve hematologic remission, cytogenetic response, and molecular response. Next slide. So here's the algorithm. I thought this was maybe an easier way to get your time points. So at 3 months, you really want to have your BCR-ABL less than 10%, right? And you want to have your patient tolerating your drug and having the optimal hematologic response. That's the green. But if your BCR-ABL transcripts are over 10%, and and they're maybe not, well, they should still be in a hematologic response, but if your transcripts are over 10%, you need to watch them closely, because if they rise at the next visit at 6 months when you're rechecking, then you need to change therapy. But again, the first thing to ask them is compliance. So if they aren't taking their medicine, the most important thing is to restart the medicine, because they can get back into remission. So that's always the challenge with this disease. I mean, we love that it's oral because patients can go live their lives and take their medicine, but at the same time, you just don't know if they're taking it correctly all the time. That's always a challenge. But at 3 months, if you don't even have that hematologic response, that is a failure. And so you really need to see, are they taking their medicine? And if they are, you really need to change therapy then. So you really want that hematologic remission by 3 months. And then at 6 months, again, if you don't have that hematologic remission and they did have it before and then they lose it, that's failure. But if your transcripts are between 1 and 10%, you want to watch closely, because you really want them under 1% by 6 months. And then next slide. At 12 months, that's the goal, when you want your transcripts less than 0.1%. And if they are between 0.1 and 1, you need to watch. And if they are greater than 1, you need to change therapy. And again, I can't stress enough that compliance is like the largest cause of failure at these time points. So really check that patients are taking their medicine correctly before you change or even increase the dose. Next slide. So failure, again, is if you didn't get that hematologic response at 3 months, or an incomplete one at 6 months, or you don't have a partial cytogenetic response by 12 months, or less than complete cytogenetic response at 18 months. So if you lose any of those responses, or you progress to accelerated or blast phase, then you need to change your treatment. And it can be just a change in dose, or it can be a change in drug. So if they're on 400 milligrams of imatinib, you can increase to 600 milligrams. Or if they are on the maximum dose of imatinib, you can change to nilotinib, which is 300 milligrams twice a day. And then allogeneic stem cell, if you've really transformed into blast phase, that is something we use in the US. And you can, in some situations, probably do transplant in your area. I don't know if South Africa has it or not, but and then discontinuation Again, very unlikely that your patients will be able to discontinue imatinib because they're in such a long remission, but it can happen. But most patients do require lifelong therapy. Next slide. So let's talk about nilotinib, which is your second line therapy. So this is a second generation TKI. It was approved in 2007. And if you look at the graph, it's the light blue line, that's the 300 milligrams. The dark blue is actually 400 milligrams and didn't do as well as the 300, which is why the dosing is 300. And then it has an overall survival, 5-year overall survival rate of 94%. It does get you into a faster CHR and higher rates of major molecular response, but there's really no difference in overall survival between imatinib and the second generation TKIs. So even though it gets you there faster, it doesn't necessarily mean it's better. The side effects include, but are not limited to, QT prolongation. That's the big one. So you need to check an EKG before you start the medication, and then just every 3 months for the first year at least, check it. Cytopenias, rash, headaches, fluid retention, and hemorrhage, alopecia sometimes. Both these drugs are teratogenic, but you can, after the first trimester, if you do have a pregnant woman, you can use these drugs. There is some data. And again, the biggest issue with nilotinib is just the avoidance of food 2 hours before and 1 hour after. And I think that makes it challenging to be compliant. Next slide. So again, the prolonged QTC is the black box for this drug, and that's you can adjust the dose according to the QTC, but you do need to check that EKG prior to starting, 1 week after, and then periodically throughout. And then look at potassium and magnesium and make sure that those are normal. In the pediatric population, growth retardation has been reported. So patients under 12 years of age at baseline had more pronounced growth deceleration. And then also hyper and hypothyroidism have been reported. So there are some pediatric specific reports but there aren't a lot of them. And so the thyroid function should be monitored. We had a whole thing about the dosing for pediatrics, and it is complicated. We actually aren't completely sure about it. The way the Max Foundation is providing nilotinib, it's actually the dosing for adults. So we're going to have to, if you have a pediatric CML patient that requires nilotinib for any reason, we recommend just coming to the group, to the advisors, and we'll figure out how to create a pediatric dose. Next slide. So again, this is just to illustrate that, we've come a very long way with this drug, with this disease. It used to be deadly. And we started off trying all sorts of things like arsenic and radiation and, interferon alpha, which you can use in pregnant women, things like that. But we've landed with imatinib and dasatinib and nilotinib, which are second line TKIs, and there's even more now, bosutinib, and lots of options. And people who achieve an MMR by 1 year, that less than 0.1% transcripts, live a normal lifespan. And the achievement of those responses, hitting those milestones, are critical to being able to live your normal lifespan with this disease. Next slide. So in summary, CML is a hematologic malignancy that results in very high white blood cell counts. It's readily treatable with imatinib, which is oral, and does not cure the disease, but significantly prolongs your life, and you can lead a completely normal life on this drug. The characteristic features of CML are splenomegaly, the elevated white blood cell count, and positive BCR-ABL testing, which demonstrates the Philadelphia chromosome. And then achieving that MMR, the major molecular response, by 1 year is critical for good long-term outcomes. So let's go over our quiz again. Next slide. And here, yeah, I gave you some references. So what type of disorder is CML? Next slide. Hopefully you all got B and C. Next slide. The main therapy is imatinib. Next slide. Right. And the translocation, next slide, is the Philadelphia chromosome. And hopefully, I'm excited that you're going to be able to both diagnose and treat patients locally for this disease, because it saves them lots of travel time. It's going to be really great for you. Do you have questions?
I do have just one question.
Mm-hmm.
How often do we have to take the bloods to ensure that, just to be able to assess whether or not the patient is
Great question. So every 3 months for that first year is critical. So baseline, 3 months, 6 months, 12 months, 18 months. So we would do 6 months the second year. But if at any point you're in that sort of watch, that yellow box, you want to repeat in 3 months. So because if they're not hitting their milestone, but they're not failing, yeah, exactly. So in that yellow box, if you're in that yellow box, you want to see them back in 3 months, regardless of what kind of follow-up schedule they're on. So if they're at 6 months, but then they end up in a yellow box, you want to see them back in 3 months. And obviously, if they fail, you need to start something else or up the dose. You want to see them back in 3 months. So whenever things change, I would say 3 months. If everybody's super stable after a year and doing well, and they're in the green box, you can go out to 6 months after the first year.
And I'm going to be sharing treatment guidelines, a protocol with you guys. I'll upload it to your Dropbox folder, and then when I'm there in November, we can print it and add it to the folder
Yeah.
with their other protocols.
Yeah,
And we've
Allison,
worked on
that slide.
yeah, and then
Yeah.
we've worked on a flow chart that outlines those intervals that Lisa was just describing. So we can have those available in each of the exam rooms, so that while you're getting familiar with the protocol, that you just have a really quick reference for when patients need these exams and follow up.
Yeah, I couldn't find the copy that had a readable size, so I didn't include it, but I figured it would be in their protocol.
Yeah, yeah. And I'm traveling there in a couple of weeks, so I'll make
Perfect.
sure all of that is available and clear in the clinic.
Perfect. That'll be really helpful. But I think whenever in doubt, see them back sooner.
Do you guys have any pediatric patients that are currently being treated in South Africa for CML?
No, we're not treating any pediatric patients.
We are not treating any pediatric patients.
Okay. And
Oh, okay. Good.
if there were a pediatric patient that was newly diagnosed, what would be the plan for that patient? Would they be would their care be transferred to the pediatric hematology team at Bloemfontein, or would they remain in
Yes,
Lesotho for care?
come to Bloemfontein. All pediatric oncology patients are sent to.
Okay. Okay.
They're sent to South Africa? I
Yes,
couldn't hear.
Yeah.
Okay.
Yeah.
Okay, that makes sense.
Okay. We do have a CML, like a pediatric CML protocol as well that we could share, but it sounds like for now just the adult protocol is relevant.
all in pediatric, please, because they are a little bit. I don't know, but I don't think pediatric is involved at all. That's
Yeah.
my advice. Yeah, just adult.
Yeah, so I'll share just the adult protocol for now, and then if that changes down the road in a couple of years, then we can talk more about the pediatric protocol.
Anything else?
No further questions from my side. Thank you so much. The presentation was very clear and on point.
Okay, good. Good. I tried to keep it simple.
Does anybody else have any other questions?
Yes, Erin.
No? All right. Okay, in that case, we can wrap up. If you have any other questions, feel free to send me an email and I can pass those along to Lisa and our team. And hopefully we get the drug soon so we can start treating these patients. All right. Well, thank you so much, Lisa, for taking the time to do this. We really appreciate it.
Of course. Thank you.
Thank you so much, Lisa, and thank you, Think Iguana team, for spending time with us on your Friday afternoon. I'm sure you're all ready to go home for the weekend. So enjoy your weekend, everyone.
Thank you so much, Lisa. Thank you,
Bye.
everyone.
And I will share the recording as well as the slides.
Okay, thank you so much.
Thanks, Erin.
Thank you. Thank you.